Beyond the gut, extra-intestinal clues and treatment strategies in pediatric IBD. Welcome back to our Pediatric IBD series. This is part 2, where we move beyond the diagnosis and delve into what lies outside the gut. Today, we're exploring 2 critical themes: recognizing extra-intestinal manifestations and complications of pediatric IBD, tailoring treatment strategies, especially for Crohn's disease. Let's begin. Thinking beyond the gut, recognizing systemic clues. While confirming a diagnosis of pediatric IBD is crucial, we must not overlook the importance of ruling out mimickers, particularly in young children. Conditions like food allergies, primary immunodeficiencies, cytomegalovirus colitis, and Clostridium difficile infection should be part of the early differential. But just as important is the identification of extra-intestinal manifestations, or EIMs. In fact, up to 28% of patients with IBD develop EIMs within the first year of diagnosis. The most common? Arthralgia and arthritis. Joint symptoms often emerge early and may precede or parallel gut inflammation. Other important evaluations include MRI enterography, or MRE, for transmural or small bowel disease, MRCP to assess for sclerosing cholangitis, ophthalmologic exam for uveitis, orthopedic evaluation for growth and bone health, hepatobiliary involvement, clues in the liver. Mild elevation of liver enzymes occurs in nearly half of PIBD patients, but the cause is identified in only 12.6% of those. Among those, ALT greater than 4x the upper limit was a notable red flag. Drug-induced liver injury tops the list of identifiable causes. Autoimmune hepatitis and overlap syndromes were each noted in 3.7% of cases. NAFLD is also emerging as a concern, especially in children on long-term corticosteroids or with obesity. Tailoring treatment in Crohn's disease, a risk-based approach. Management of Crohn's disease must consider disease behavior and severity. Low-risk Crohn's, defined as B1 phenotype, non-stricturing, non-penetrating. Induction therapy may begin with exclusive enteral nutrition and/or corticosteroids, up to 12 weeks, followed by thiopurines or methotrexate for maintenance, especially if patients show clinical response after steroid tapering, typically after 3 to 4 weeks. High-risk Crohn's includes extensive colonic involvement, deep ulcers, stricturing or B2 or penetrating or B3 behaviors. These patients warrant early biologic induction, often anti-TNF agents such as infliximab or adalimumab. In some centers, combination therapy with immunomodulators is used from the start to reduce anti-drug antibody formation. Biologics in monitoring, optimizing for the future. Recent Canadian guidance now promotes early use of biologics with body surface area-based dosing in children under 10 years old. More importantly, therapeutic drug monitoring, or TDM, has become a cornerstone of biologic management. Checking trough levels and anti-drug antibodies, adjusting doses or intervals based on levels, and when needed, regimen intensification or switching classes of biologics. This approach is not only cost-effective, but it also improves outcomes. Special considerations: male patients and malignancy risk. Some experts now recommend using methotrexate instead of thiopurines in boys, citing a lower risk of hepatosplenic T-cell lymphoma, a rare but serious concern. And finally, dose reduction strategies for both cost and safety are increasingly being considered in well-controlled patients. So remember, pediatric IBD management goes beyond the bowel. From joint pains to liver panels, from enteral feeds to biologic regimens. It's a comprehensive journey that requires vigilance, personalization, and up-to-date knowledge. Stay tuned for Part 3, where we'll tackle ulcerative colitis and long-term follow-up strategies. Until then, keep learning, keep questioning, and keep caring for the whole child.